Hi guys, welcome back to my channel. My name is Khadijat Adeshola, and in my channel I talk about everything related to women and midwifery. So to all my subscribers, I say thank you so much for subscribing to my channel. And for you who come across my channel for the first time and you haven't subscribed to my channel, please, if this looks like what you're interested in, kindly subscribe and don't forget to turn on the notification button when you do that, so you get notified whenever I post a new video on my channel. So in my channel, I talk about everything related to women and midwifery, and especially midwifery in the UK. Talk about midwifery. I talk about midwifery in in all parts of the world, really. So, but for now, I really talk more about the UK, practicing midwifery in the UK and in Nigeria as well, because I have practice in Nigeria as a midwife and I'm currently practicing in the UK. Basically, I practice in Nigeria more than in the UK at the moment. Like, well, you look at how many years I worked as a midwife in Nigeria, it's more than how many years I have worked in the UK as a midwife. So if you've been following my channel before, when I started working in the UK, I started working in the antenatal ward and I shared my experience in there about the antenatal ward within the NHS. So today I have now been rotated to another department, which is the delivery suite. Is also known as labor ward in some trust or in some hospitals. So I'm just going to tell you about my experience in delivery suite. So now, whether you work in any of the whether you work in any of the NHS trust, that's any hospital, in as much as it is NHS, their delivery suite or labor ward, they aim to have one-on-one care to women in labor. That is the aim, and like to have 100% one-on-one care in labor. However, it might not really be possible in some time, but most of them aim to have at least, if not 100% one-on-one, there should be like 99 point something percent one-on-one care to women in labor. So now, the composition of labor ward differ from one trust to another. In some trusts, labor ward is separate, like they only have a labor ward and every other department are also separate. While in some trusts, the labor ward consists of the theater as well, like they are in the same floor, the labor ward, the theater, and recovery and recovery or triad. So they have a kind of one coordinator, someone coordinating that the whole aspect. Why in some places they only have labor ward and whoever is coordinating labor ward is only coordinating labor ward, and they have another one triage as well. So now I'm going to be talking mainly about labor ward, really, and labor ward like the delivery suite. That's what I'm going to be talking about only. Basically, what is expected of you when you're taking care of a woman in labor. Yeah, that's it. So now in the labor ward now or delivery suite, they have midwifery-led betting unit and they have a kind of consultant led betting unit. So I'm just going to be explaining what is expected of you in the two category basically. And sometimes this is kind of, it's going to be like a kind of national standard kind of, but there is still going to be a kind of modification based on each trust. So what I'm saying might be slightly different from what you do in your trust, but it shouldn't be 100% different, because the main thing that each and every one of the trusts are aiming for is to provide effective, high standard quality care to women in labor according to the NMC code of conduct. So they aim to preserve, practice effectively, preserve safety, promote professionalism, and and trust, and also to prioritize people. So that is the aim of the care that is being rendered in the to women in labor. So little things I'm going to be saying might be a little bit different from the trust you are working, but it shouldn't be, totally different. So this video is also important, or is good for you if you're still in your home country, or you newly migrated to the UK, you're still preparing for your OSCE or all of that, or you're having your next rotation to be in delivery. So this is just going to tell you the overview of what you are expected to do. So basically, in delivery suite, you are expected to just manage labor cases. And in most cases, active phase of labor. So if they are not in active phase of labor, they are mostly in another, in another unit, maybe in the antenatal, an antenatal ward, or some places may have early labor space. Like, so labor cases in labor ward now, you're expected to manage labor cases. So those in active phase of labor from 4 centimeter and above. You may be required to manage people with, in early labor if they are requiring epidural, if they want epidural as well. Another thing is people that has undergone a phase of the induction of labor, and they are now waiting for their water to be broken, so they can send them down to delivery as well for their water to be broken, and for them to have an established labor and be managed in labor. Then another thing is high risk patient as well might be transferred to delivery suite because they have one-on-one care in delivery suite. High risk patients like those with eclampsia for uncontrolled diabetic, uncontrolled hypertension, all of those things, people requiring sliding scale. In some trusts they offer, or they can do sliding scale in antenatal ward, while in some trusts sliding scale is only done in delivery suite. So it depends on whatever is happening in your trust. But the main thing, and also you can be asked to manage preterm labor as well. So basically, what you do in delivery suite should be mainly management of patients in labor. So now, for me, this title is like delivery suite experience. How am I finding it? To me, it's so interesting, and you know, not really totally different from what we do back home, but because of the policies and how things are done here, so it's make it a little bit different. For instance, here they have a lot of policies, there are a lot of things that you need to take into consideration before taking action. And here, you're never alone, unlike back home. So in delivery suite now, when I got the first thing, of course, you'll be like, understudy people for a couple of weeks before you start working on your own when you really rotated to, a different department. And that is necessary for you to have an understanding of how things are done, where do they keep things, and all of that. So basically, management of women in labor, you still do your, 4 hourly and VE, just as we do back home in active phase of labor. However, you can sometimes it's my favorite is based on, you can do VE based on your discretion. Like maybe the woman is complaining, oh, she feel like pushing or something, you might just do a VE to confirm. Standard is to do VE every 4 hours. However, in some cases, when you are augmenting labor with either, you know, or oxytocin. Okay, let's talk about oxytocin first. When you are augmenting the labor with oxytocin, some consultants do plan that you check, you do VE 4 hours from oxytocin, not 4 or 6 hours from the commencement of oxytocin, not 4 or 6 hours from the last examination. So it depends on how dilated the service was when they do the last examination. But basically, it's around, you don't keep women without examination. She's contracting or not more than 4 to 6 hours before the next examination. She's contracting well, you want to do every 4 hours, right? So back home as well, how we expected labor to progress, it may be 1 centimeter per hour per hour, but that doesn't work for everybody. You look at 0.5 centimeter at least per hour. So within 4 hours space, there should be a kind of 2 centimeter progress. If there is no progress, of course, just as back home, you want to know why there is no progress. Is it that the woman has not been contracting well? So do you want to augment the labor, or the head is not coming down, or is there any other thing that is affecting it not to dilate and all of that? So while the woman is in labor now, if it's in delivery suite like high risk consultant care, most of the time they have to be on CTG monitoring. However, if it's in midwifery led person, they don't necessarily have to be on continuous CTG monitoring. So now, if the patient is on continuous CTG monitoring and not on epidural, they can always, go to the toilet to pass urine at least every 4 hours, and also you hydrate them, ensure that they are well hydrated, and ensure that you are closely monitoring the CTG. So you do in my trust, basically we do the CTG stickers every 30 minutes, and we do fresh high every 1 hour. Fresh high is that you call someone else from who is not in the room with you to come and have a look at the CTG, to clarify it, to be sure that everything is still fine. And at any point, if you are concerned about the CTG monitoring, then you escalate to the midwife in charge, and also you get doctor to review the CTG if needs be. So basically, that is all you do, continue doing, and also you try to chat with the women. That's one thing that is different from us, from what we do back home. Here now, you're with this woman 24/7. Like if I'm in a 12-hour shift, this is where you'll be. You're with her, so it can be boring. So you have to try to establish conversation, try to talk to the women and a partner and a betting partner. Sometimes you have to create a kind of conversation. You have to create a kind of conversation, so the room is not going to be boring. If it's like a night shift now, you can encourage her to sleep if she's not having pain. Or if she's on epidural, you encourage her to sleep or something, and you dim the lights, all of those things. Shall try to engage the women. You can try to, sometimes ask her if she's, what does she know what she's expecting? This is her first baby. What happened in her, just those things. You have to learn to engage your women in labor. Otherwise, the room is going to be very, very boring, especially when you start, when she's like, for instance, maybe she come down for ARM, and she just like maybe just 2 centimeter. By the time you start monitoring, she might not even have that baby in your shift. So you might use the 12 hours shift, 12 hours you have in the room with her. So the room is going to be boring. So you basically need to learn to engage your women. Learn to engage your women. Another thing I do also is to gain consent for everything, like for active management of third stage of labor. You can discuss with her if she wants active management, or she wants physiological management. If she wants the baby to have vitamin K, yeah, we do vitamin K back home as well, but here you have to seek consent before you give the vitamin K, unlike back home. So you have to seek consent. If she have the right to always say, she can say she doesn't want vitamin K really, and she can say she wants the oral vitamin K instead of the injection vitamin K. So you basically need to engage her to seek consent for everything you're doing. For VE as well, you have to seek consent as well. You have to tell her the reason you need to do this, the VE and everything. So it's more like discussion, having consent, gaining consent from every little things you're doing to the women, and that is just is a routine. You just continually monitoring it. So how often did you do the observation in labor as well? If she's on continuous CTG, yeah, continuous CTG, and not on epidural, so you do the full set of ops 4 hourly. That's the temperature, blood pressure, respiration, what's remaining, oxygen saturation, all of that. You do them every 4 hours. If she's on epidural now, you have to do the epidural ups every 1 hour, because epidural can reduce, the women blood pressure. So you have to do epidural every epidural ups every 1 hour, which has to do with the, checking the blood pressure, checking the pulse rate, and checking the height of the epidural block. So how high it is and how effective it is. You also need to check if she can raise her leg or something. So you do those ones every 1 hour, and that is if she's on epidural. If she's not on epidural, you just do, yeah, and she's on continuous, CTG monitoring. You do set of hops every 4 hours. Now, if she's on oxytocin, each trust will have, their policies on how you titrate the oxytocin. Each trust will have how they use the oxytocin, how many you should use and how many you should. So you should be aware about the policies, the oxytocin use policies in your trust. So most of the time they use a syringe driver. So you have to titrate it, you increase it if she's until she have adequate contraction, just like back home as well. You increase it until she have adequate contraction. You start from the lowest, of course, based on wherever your trust agree to use. You start from the lowest and you continue increasing it. However, women on oxytocin have to be on CTG monitoring. So you titrate according to the contraction, according to the how the baby is also tolerating the contraction. At any point, if the CTG become gradually evolving, compensating, all of that, you may have to, turn down the oxytocin as well. And if at any point you have deceleration more than 2 minutes, you have to put the emergency buzzer. You have to stop the oxytocin and put the emergency buzzer straight away. So that's basically something what happened in the delivery suite. So a patient can be on oxytocin, a patient can be on epidural. If they are in any of those two, they have to be on continuous CTG monitoring. They can also be on continuous CTG monitoring if they do not meet the criteria for midwifery-led birthing units, which is already been set by the trust. So high risk pregnancy, of course, they are not on midwifery-led birthing unit. The midwifery-led birthing unit is only taking care of low risk pregnancy, and they don't have to be on continuous CTG monitoring. You have to, in active phase of labor, I think you listen to the fetal heart rate every 15 minutes, but this might differ from what your trust does. And when she's in second stage of labor, you have to listen to the fetal heart rate every 5 minutes in midwifery-led birthing units. However, in consultant leg or high risk pregnancy, you have to put them on continuous CTG monitoring. You have to do the CTG stickers classification every 30 minutes, and you have to do fresh eye every 1 hour. At any point when you're concerned about the CTG, you have to, escalate. Even if the consultant plan to commence oxytocin, if CTG is not fine or you're not happy, you still have the right not to commence that oxytocin. The consultant just come on the ward run and go. So you're the one that is there. Whenever you notice anything, know what you need to do. So for you to really practice in this country, you need to be aware of your trust guidelines and policies. And I did make a video regarding that earlier, that make sure you have an idea about the policies that exist in your trust. So when you are faced with that something related to that situation, you know that there is a policy. For instance, now another thing that can happen in labor is maybe patient have a temperature in labor. So each trust have how many hours, have policies or guideline on what you do when there is a temperature spike. Some people say if there is a temperature spike of above 37.5 in 2 different occasions, you have to do a septic screen for an antenatal lady. And if you do first now is 37.6, you have to repeat again in an hour. So you have to give paracetamol. In some places they will buy, if she can have paracetamol, you can give paracetamol. Otherwise, in some trusts they might be like, no, but you want to give paracetamol, a patient is having 37 point above 37.5 temperature, you give paracetamol and you will check the temperature in an hour. If after an hour you recheck the temperature and it's still above 37.5, then you need to do a septic scan. You need to get the doctor to prescribe IV antibiotics to the woman in labor. And also continue checking the CTG as well, continuing monitoring. So, and if you think the labor is not progressing, you need to get the doctor to review the lady. If the woman is fully dilated, do fresh eye every 30 minutes. In my trust, they give passive hour depending on what the CTG is saying. If CTG is fine, no hypoxia, and the woman is fully dilated, you can still give her about 1 hour passive hour before she starts pushing. However, if she's feeling the urge to push and she's already fully dilated, there's no point. Like if naturally she wants to push, she can push basically. But you have to be sure what the trust says about all of those things. So I'm just going to mention the few policies that are related to delivery suite or labor ward that you need to have an idea of. In some cases, in some trusts, they have a list, a sticker of the oxytocin policies, how you should dilute the oxytocin, how you should triplate the oxytocin. They have it in each of the rooms, so that give you an idea. So you don't need to really cram it on your head, but you need to have an idea that okay, this is what happened. You can always ask as well. If you are not sure, you can ask your colleagues and you can check the guideline. There's computer everywhere. You can check the guidelines to be sure of what you're expected to do. So one of the policies you should idea of when you're working delivery is oxytocin use, CTG, intrapartum CTG monitoring, oxytocin use, intrapartum CTG monitoring, bladder care in labor, septic screen in labor, active management of third stage of labor. How about management of women with gestational diabetics or diabetics in labor and all of that. Yeah, that's another thing I need to mention. If the woman is diabetic, you need to check the blood sugar every 2 hours according to my trust. It might be different from your trust, so you do the blood glucose monitoring every 2 hours, and if it is above 8 you have to change it to every 1 hour, and if it's above 10, then they need to start a sliding scale. So that is the policy. So, and it might be different from your trust, so you need to be aware of that policies as well. Then another thing they do here is GBS positive, group B streptococcal clinical positive. They really take that seriously, and any patient on that uh, you know any patient that's positive for that, in as much as their water has gone, they have to be on IV antibiotics. So you need to confirm from your trust. You need to check your trust to see what they say about that for you. So basically, comparing delivery suite to antenatal ward, to me, I think workload wise, I still prefer delivery suite. Workload wise, I prefer delivery suite because it's one-on-one care, and you can't really have more than one high risk patient in delivery suite. However, in antenatal ward, you can have all your 8 ladies can be high risk, yes. So it depends on your trust, how busy your trust is, how my trust is a kind of big trust. In my hospital is kind of big hospital with, and they have a lot of high risk cases. So in our antenatal ward is usually full of high risk patients, and you have at least 8 to 9 high risk patients to manage in your trust. However, in delivery suite, if you're having an high risk patient, you're only having just one high risk patient. You can only have 2 or 3 patients in delivery suite, but most of the time, maybe those that have that have delivered, or those that just came in because they are not feeling baby movement, that you just put on antenatal CTG. They are not the people that are actually in active phase of labor that you will have. So workload wise, I prefer to be in delivery suite. So if you're a midwife in the UK already practicing, you can Please say in the comment section, which department do you like working in? Do you like most? Do you prefer antenatal ward? Do you prefer delivery suite? Do you prefer postnatal ward? And do you prefer trial theatre? Which one do you prefer, or the community? And you can also say why you prefer that particular department. So if these videos interest you, please share with your friends and colleagues, and also like, comment, and subscribe to my channel. If there's something you think I should have said, or there's something they do in your delivery that I did not say in this video, please kindly say it in the comment section. For me, I think I have said everything that we get to management of patients in labor in delivery suite. So basically just about patients in labor. I'm not talking about different other patients. So I talk about patients in labor in, like midwifery, low risk patient, which you don't have to do CTG, you just have to keep monitoring. Sometimes I do indwelling catheter, especially if she's just like 3 or 4 centimeter and she's on epidural. But however, if she's like 8 centimeter already, I'll just do in and out catheter. That is basically what I do. So, and also I talk about gaining consent for everything you're doing for the lady, and also I talk about gaining consent for everything you're doing for the lady, and also chatting with your lady. To this say, thank you so much for watching, and don't forget to like, comment, share, and subscribe to my channel. Thank you. Bye. I'll see you in my next video.